Okay, so today I'll be presenting on anxiety disorders.
There are three fairly common types of anxiety disorders: generalized anxiety disorder, panic disorder, and social anxiety disorder. Each one of them is a little bit different. The most common, or generalized anxiety disorder, is normally characterized by excessive constant worrying. That worrying can be about a variety of different topics and can be so devastating for a patient that sometimes they will have problems with their sleep, their eating schedules, and even sometimes manifest with physical symptoms such as headaches, abdominal pain, and heart racing symptoms as well. Panic disorder is a little bit different. Panic disorder is a problem with recurrent panic attacks and concern of having recurrent panic attacks in the future. A panic attack normally is a short period of time, normally 15 to 20 minutes or so, of severe anxiety, sometimes chest pain, sometimes nausea, sometimes a feeling like you are about to die almost. And these can be very devastating for patients. Last is social anxiety disorder. Social anxiety disorder normally relates to anxiety that happens in regard to having a social experience. That may be sitting down and having a conversation with somebody, being in a large group, public speaking, and then it becomes a disorder rather than just being nervous about a presentation when it becomes so pervasive that it's starting to be a problem in your ability to cope or to be in that setting, or you're actively avoiding those settings.
Alright, so different types of anxiety that I found were general anxiety disorder, panic disorder, phobias consisting of specific phobias as well, agoraphobia, social anxiety disorder, and separation anxiety disorder. So, how common are anxiety disorders? In any given year, the estimated percent of U.S. adults with various anxiety disorders are 7 to 9 for specific phobias, 7% for social anxiety, 2 to 3% for panic disorder, 2% for agoraphobia, and 2% for generalized anxiety disorder, and 1 to 2% for separation anxiety disorder. And this is most commonly found in women. So generalized anxiety disorder is also abbreviated as GAD. The presence criteria for this are the presence of excessive anxiety and worry about a variety of topics, events, or activities. Worry occurs more often than not, at least 6 months, and is clearly excessive. The worry is experienced as very challenging to control. The worry is in both adults and children and can easily shift from one topic to another. The anxiety and worry are accompanied with at least three of the following physical or cognitive symptoms, and this could be edginess or restlessness, tiring easily, so you're feeling more fatigued, impaired concentration or feeling as if though the mind goes blank, irritability, increased muscle aches or soreness, and difficulty sleeping. Panic disorders. So the criteria for panic disorders includes the experiencing of recurrent panic attacks with one or more attacks followed by at least 1 month of fear or another panic attack related attacks. And the attacks are abrupt and have 4 or more of the following 13 systematic symptoms, which includes palpitation, pounding heart, sweating, trembling, shortness of breath, feeling of choking, chest pain or discomfort, nausea, feeling dizzy or lightheaded, numbness or tingling sensations, feeling of unreality, fear of losing control or going crazy, and fear of dying. Phobias. So there's a lot of different phobias out there that people have, but just like criteria for it is unreasonable, excessive fear. So the person will feel excessive or unreasonable, persistent, and intense fear triggered by a specific event or situation that they're put in. And then immediate anxiety response. The fear reaction must be out of proportion to actual danger, so they'll kind of have more fear in them than they, like in a regular social setting, someone else might have. The recognition, the fear is irrational or not required. Adults with specific phobias had to recognize that their fears are out of proportion to reality. And then avoidance or extreme distress, the sufferer goes out of her way to avoid objects or situations that might cause them anxiety or panic attacks. Life limiting, the phobia significantly impacts the sufferer's school, work, or personal life, and not caused by another disorder. Many anxiety disorders have similar symptoms, therefore your therapist must rule out other disorders before diagnosing you with specific phobia. Agoraphobia. This is the intense fear or anxiety prompted by actual or predicted exposure to two or more of the following situations. People using public transportation, being in open areas, being in closed off areas, standing in a line or a crowd, being alone outside of his or her house. They avoid all of these situations because the individual believes they may become stuck or help might be unavailable in an event that the individual begins to panic. The situations usually incite fear or anxiety. They are avoided, require help from loved ones, or endured with a strong fear. The fear or avoidance is persistent, as if typically lasts about 6 months or longer, and the individual is in significant distress. And another medical condition exists alongside of this disorder. The fear or avoidance is usually excessive. The fear of the avoidance is not better explained by the symptoms of another medical disorder or situational circumstance. So social anxiety disorder, criteria for this is persistent intense fear of being in a social setting. This could be because they believe they're going to be judged, embarrassed, or humiliated. Avoidance of anxiety-producing social situations or enduring them will intensify fear and anxiety. Excessive anxiety that's out of proportion to the situation is usually what occurs in social anxiety. And the fear or anxiety that is not better explained by medical condition, medication, or substance abuse. Separation anxiety disorder. This is when someone experiences excessive or unwarranted fear of anxiety due to separation from whomever he or she is attached to. And usually the criteria is 3 or more of the following: regular excessive distress when separated from the home or certain individuals. This could be like with a baby and a mom. They have a lot of separation anxiety at first. Regular excessive worry about losing these individuals or about them being harmed. Regular worry about experiencing an unfortunate event that causes separation from their attachment figures. Persistent reluctance or refusal to go anywhere or do anything out of fear of separation. Persistent reluctance or refusal to sleep away from home or from the attachment figures. Frequent nightmares about separation, and frequent complaints of physical symptoms such as headaches, nausea, and this is when they're separated from the person they have anxiety from being separated from. The individual's fears and anxiety are persistent, lasting at least 4 weeks in children and adults for at least 6 months or longer. The separation, fear, or anxiety causes clinically concerning distress or impairment in important areas of life, and the individual's excessive fear or separation cannot be attributed to another mental disorder. So the main treatments for anxiety that I found are psychotherapy, cognitive behavioral therapy, which we'll talk about in a later article, exercise, medications, and these usually include antidepressants or anti-anxiety medications, also known as anxiolytics. So the first article that we'll be talking about is the association of child irritability and depressive anxious mood profiles with adolescent suicidal ideation and attempts. So the introduction, suicidal ideation and suicide attempt are common in adolescents and a public health concern. Childhood depression is a risk for suicide attempts and often occurs with irritability. So the methods that they used in this study were participants were drawn from the Quebec longitudinal study of child development, a representative sample of 1,430 infants born in Canada province in 1997 to 1998 were followed up until the age of 17. This being said, they were mostly rated by their teachers for with the behavior questionnaire during their elementary years. And children were also assessed for depressive and anxious moods along with irritability. And then serious suicidal ideation and suicide attempt were assessed at ages 13, 15, and 17. So the results of this study, the participants were also 47.3% male and 754% female, and they were followed up to the age of 17. Group-based multi-trajectory modeling identified the following profiles: combined no irritability and low depressive anxious mood with low irritability and low depressive anxious mood was about 831 of the sample, which is 58%. Moderate irritability and low depressive anxious mood was 353 of the sample, which is 24%. High depressive anxious mood only was about 94 of them, which is about 6.6%. And then high irritability and depressive anxious mood was 152 of them, which is about 10.6%. So the conclusion of the study came to the joint development of irritability and depressive anxious mood showed stable profiles across middle to late childhood. Expression of irritability during childhood are associated with a significant risk for suicidal behaviors during adolescent years. The risk was especially high when high levels of irritability were accompanied by high levels of depressive and anxious moods, and this was found particularly in girls. So the next study was non-suicidal self-injury, how categorization guides treatment. So formerly called self-mutilation, self-injury, or self-harm, non-suicidal self-injury, which is also known as NSSI, is the deliberate and direct altercation and destruction of healthy body tissue without suicidal intent. So these are the people that like to harm themselves without, with knowing that they're not going to kill themselves. So NSSI can be classified as non-pathological and pathological. Non-pathological consists of body modification practices, so this is going to be your excessive body jewelry or tattoos. And then pathological is going to be typically like the emotional regulation of actually harming yourself to get that release of distress. So why do people self-harm? So the pathological approach is for emotional regulation and distress tolerance, and that provides temporary relief from disturbing thoughts or feelings or emotions. So this is going to be when somebody is like cutting themselves, they would feel that quick relief of the sense of, oh, I feel better now. but this is only going to be temporary. It's not going to last very long. So there were 4 different types of different classifications. The first 2 being major and stereotypic. So the major includes infrequent acts that destroy significant body tissue, such as eye enucleation and amputation of body parts. They also gave the first line of psychotherapy treatment for each of these. So the first line for this one would be considered atypical and antipsychotic for the psychotic patients who are preoccupied with religion or the Bible or sexuality. And this is kind of, when you see people like this, you want to make sure like this will start out with maybe like excessive tattoos or excessive body piercings or things like that, or like big switches in their life, like big haircuts or anything of that sort. So then from there it'll get intensively worse if the person is having these thoughts. Stereotypic is acts more commonly associated with severe and profound mental retardation. This includes repetitive eye gouging, biting lips, the tongue, cheeks, and or fingers. So this is for more of the mental disorders of the patients. And to do treatment for this, you would start with a moderate dose of the selective serotonin reuptake inhibitor and slowly add an atypical antipsychotic followed by a mood stabilizer, then clonidine, and then a beta blocker. And then also primary treatment before the medication would be to have behavioral therapy. The next 2 types were compulsive and impulsive. So compulsive encompasses repetitive behaviors such as severe skin scratching and nail biting, hair pulling, and skin digging. This would be like somebody that's not like harming themselves like an impulsive person, but they're kind of just like things, little habits that they do that would demonstrate this. The first line of therapy would be typically seek help from dermatologists. This is more for your skin scratching type of people or skin digging. Or you also might seek help from a family physician. And then they work on a psychiatric treatment is limited, but SRRIs, lithium, benzo, and atypical antipsychotics may be effective for helping compulsive people. The impulsive is more of the common thing that you would see, and this consists of acts such as skin cutting, burning, and carving. So these are your people that get the most of the temporary relief, and then they follow up with continuing to do these acts to feel more relief for emotional regulation. This should be treated by receiving pharmacotherapy for underlying psychiatric illnesses such as general anxiety disorder or post-traumatic stress disorder or depression. So the bottom line to this article was pathological self-harm can be categorized as major, stereotypic, compulsive, and impulsive. Studies have shown psychotherapy are effective primary treatments for several types of these self-harm issues, and pharmacotherapy should be used for these patients with underlying psychiatric illnesses, and this could be like your post-traumatic stress and general anxiety disorder patients. So the last test is CBT for adolescents with anxiety, mature yet still developing. So the introduction to this was anxiety disorders are common in adolescents from ages 12 to 18 and can contribute to a range of impairments. In the article, it will explain how cognitive behavioral therapy, or CBT, for adolescents with anxiety and how it kind of helps them throughout the process. So assessing this in mixed children and adolescent samples. The studies find that approximately 60 to 80% of youth show clinically significant improvement, and that in more conservative measures of remission, evidence rates is from a range from 50 to 70 when these children are actually seeking the route of CBT rather than medications. So this is strictly just an adolescent sample of using CBT. So the outcomes were randomized clinical trials evaluating adolescent are fairly comparable to those from trials with the mixed children or the mixed age samples. Studies of adolescents report significant improvement from pre to post treatment assessments, medium to large effect sizes, and superiority over control conditions. Significant improvement in the symptoms have been measured through a variety of assessments, and these include diagnostic interviews, self-report, and behavioral assessments. So, brief cognitive behavioral therapy was one type that they used, and this is an alternative of delivery and condenses core components of the CBT and removes elements with less empirical support. So, brief CBT maintains the integrity of evidence-based protocols, but delivers the intervention fewer or less times than normal treatment throughout months would take. In one trial, they examined this with 26 adolescents with panic disorder. They were assigned to receive either weekly panic control treatment, which went from 11 to 12 weeks, or they did an 8-day brief CBT instead of doing the weekly ones. Brief CBT yielded medium to large effect sizes at the post-treatment and 6-month follow-up assessments with significant reductions in anxiety comparable of those standard duration weekly treatment took. The next round of CBT treatment would be computer and internet delivered, and this was kind of for more of the young people because this is our age now, we're all on technology and things of that sort, so it made them more comfortable to actually receive treatment. These programs are completed online or through downloadable content with a therapist at a clinic or at home with modest remote therapist consultation. These programs are for all ages and they had weekly follow-ups through emails or phone calls. Active treatment conditions showed significantly greater reductions in anxiety compared with waiting list condition at the post-treatment, and remission rates were at 78% for the internet and internet-delivered CBT group, and 81% for the computer-based CBT group, which this is kind of like the internet was more of people come in and meet or have like therapists online, and then the computer-based was a downloadable treatment. So the conclusion, overall randomized clinical trials demonstrate that approximately 2/3 of youth who received the CBT showed clinical improvement, and rates are even higher when treatment is combined with an antidepressant medication. The data suggests that it is reasonable to conclude that young adults have comparable positive responses when they get cognitive behavioral treatment. And then those are my sources.